I'd like to acknowledge the local custodians of the land in which we meet this afternoon and honour elders past, present and emerging. I'm Mel Wilkinson from the Hunter New England Central Coast Primary Health Network Education Team. Welcome. Today's Mastermind, we have Sarah and James. Welcome. Thanks for being here with us today. It's an important topic. There's no place like home, hospital avoidance strategies for general practice. Just a bit of housekeeping. There will be a poll at the end of the session. We strongly encourage you to complete that. Your feedback's really important to us. So we use those for planning other education events. So please take the quick 5 minutes to complete that poll. We also encourage any questions. This is your chance to ask our presenters any questions that you might have on the topic and pop those into the questions box. That would be fantastic. Also, just a reminder, we are being recorded and a copy of this and the presentation will be available in 24 hours on our website in the Education Library. So today we have Sarah Houlihan and James McNeil with us. They are both PCIOs with the Primary Health Network and they're going to present today. I'm going to hand over to you now, Sarah. Thanks, Sarah.
Cool, thanks Mel. So thank you everyone for joining us. We know this is a really busy time, so I do appreciate your time coming to join us today. I'd like to acknowledge the traditional owners of all the lands that we are on today and pay my respects to elders past, present and emerging. And I'd also like to recognise how important this topic of potentially preventable hospitalisation is, especially for our Aboriginal and Torres Strait Islander communities, given the high incidence of comorbidities and chronic diseases that we know exist with this cohort of patients. So by the end of this session, hopefully you will have an increased understanding of what is meant by the term potentially preventable hospitalisation and hospital avoidance strategies. We also aim to help you better understand the most common potentially preventable hospitalizations, how to identify these patients in your practice, and provide you with ideas for implementing some hospital avoidance strategies. Besides the obvious that we want to keep patients out of hospital, especially at the moment where the acute care sector is likely to struggle, the timing of this presentation has been intended to coincide with the College of Nursing's Nursing in the Community Week, which recognises the role of all the nurses who work in primary care, providing care to patients with the idea of nurses where you need them. So when we're talking about potentially preventable hospitalisation, it's really important that we remember a couple of things. It doesn't mean that the patient wasn't sick enough to go to the hospital at the time that they did. And it's also not a judgment on the quality or the quantity of care that you're providing in your practice. Rather, it's a focus on conditions where we know that early detection, intervention and management can prevent deterioration to the point that the patient may need to go to hospital. So the reason that hospital avoidance strategies are so important in primary care is because it's essentially the reason that GP and practice nursing roles exist. The role of the GP recognises that primary care providers are usually the most accessible and trusted care option, which provides continuity of care over the person's lifetime with a focus on prevention support and everyday health and wellness. And hospital avoidance also reinforces the incredibly important role of the general practice nurse in providing education, early intervention, advocacy, support, care coordination, and as a member of the multidisciplinary care team. So why are we worried about it right now? I think that's pretty obvious. Identification and management of conditions that are likely to become potentially preventable hospitalizations are always important, but at the moment, of course, there is a greater need to do whatever we can to keep patients well and at home, to reduce potential exposure to COVID-19 and also reduce burden on the health system. And while the purpose of today's session is not particularly about COVID, given the current situation, it makes sense that we included these resources, which are available for general practice who are managing COVID-19 positive patients at home. The web address for these resources on the RACGP website is at the bottom of the slide. And I've also included a link there to the events page, as the RACGP are running a collaboration session with GPs next Monday, the 20th, where they can discuss the role of GPs managing COVID-19. And they're looking to identify what the training and support needs are for GPs to confidently care for their COVID positive patients at home. Because of course, COVID-19 patients still require routine care for their normal health issues. So especially if the patient's normal chronic disease is, for example, a respiratory condition, the roles of the GP and public health may intertwine. As a reminder, these slides, a copy of them will be available on the education page. And what I've highlighted here is actually the patient guide to managing COVID-19 at home with assistance from your GP. And that includes a COVID-19 action plan, a managing my symptoms flags page, and also a daily symptom diary to assist patients identify any symptoms that might be deteriorating, and so that they know when to seek medical attention. So the Australian Institute of Health and Welfare maintain a register of the most common potentially preventable hospitalisations, and these loosely fit into three categories, being vaccine preventable, acute conditions and chronic conditions. The last update was completed in January last year, and it'll be interesting to see how the condition list might change as a result of the pandemic. And presumably COVID-19 vaccination will also be added to the vaccine preventable list, given that we now have a good understanding of the efficacy of COVID vaccines in preventing hospitalisation, ICU admission and death. So in Cat 4, which most of you have in your practice, it's particularly great when we're talking about potentially preventable hospitalisations, because you can see there in that green box that there's filters to search for lots of the conditions that were on that potentially preventable hospitalisations list for the chronic conditions. And so when we use these filters in conjunction with searches for chronic disease management, health assessments, nurse follow-up visits, we can identify any patients that might be slipping through the gaps, and also review the actions of the patients who are managed really well to be able to see what we can implement to work for all patients. So in the last 2 years, the has been directly impacted by the pandemic, and most notably Breastscreen services, and currently all New South Wales Breastscreen services have been suspended. And even though these have been suspended, Breastscreen New South Wales is still providing care and screening to women who've been recalled for further investigation. So with bowel cancer being Australia's second biggest killer, with 1 in 7 women developing breast cancer in their lifetime, and cervical cancer occurring more in people who have never been screened or don't screen regularly, we need to encourage both our male and female patients to continue bowel and cervical screening when they're due, and communicate to women to be breast aware and to contact their GP or practice nurse if they experience any changes. So please remind your patients that you are a COVID safe place and you are still providing preventative health care like cervical screening. In the current climate, COVID-19 has drastically changed the way in which we interact, communicate and care for our patients and our wider community. So reminding your patients to maintain their health, specifically through participating in cancer screening, doesn't need to be time-consuming to be effective. So for example, you can access the National Cancer Screening Register in HPOS via Proda to check on a patient's screening status really quickly. Much like looking up an immunisation in the air, you just need the patient's name, Medicare number, date of birth to be able to view their previous screening history. If a patient's overdue for bowel screening, you can reorder a bowel kit to be posted to the patient's address, For patients who are overdue for cervical screening, that's something that could be offered in practice. Or for women who are over 30, never screened, or at least 2 years overdue for their cervical screening, they're eligible for self-collection, which needs to be done under the supervision of their qualified healthcare professional. So if you don't currently have access to the National Screening Register, or you'd like more information about that, please reach out to your primary care improvement officer, and we can certainly provide help with that remotely, so that you can access this in your practice. And then the opportunity is to encourage your patients to continue screening and maintaining their health at the moment. You might consider using social media and your website to communicate key messages regarding cancer screening during the COVID-19 restrictions, reminding patients that leaving the house for medical appointments is absolutely allowed. And there is lots of social media and web content that's already been developed that you can access. And if you are not sure where to find that, please do let us know, and we can get those through to you. Some other things you might do is consider changing your on hold message to include preventative health reminders, sending your reminder letters to your patients regarding screening, and encouraging, especially your female patients, to be contacting you if they experience any breast changes that they're concerned about. And lastly, consider use of your MBS item numbers, specifically the recently updated smoking cessation numbers that are available to be used via telehealth. So nurse follow-up care for the vulnerable patients really can't be emphasised enough, and when these items are utilised well, can really make a substantial difference to patient care. So first we have the 5 annual nurse follow-up visits for patients with chronic disease who have a GP management plan or a team care arrangement. In most cases, these visits would benefit from being spread across the year as a touch point with the patient. But if there's an immediate issue requiring some intensive support, whether that be a new diagnosis or a recent hospital discharge, there's no reason why you can't use a few of the visits in quick succession and then just spread out the remaining visits throughout the rest of the year once the patient is stable. Then next we have the 10 annual follow-up visits for our Aboriginal and Torres Strait Islander people of any age with a current 715 health assessment. So again, these visits may be planned out over the course of the year, like a monthly check-in, or they can be utilised to provide lots of support early on, with remaining visits being touch points, just to see how things are going. So a great example of that model can often be the follow-up of infants. So for the first few months, you might be regularly seeing the little one to monitor their measurements, provide support with feeding and sleep, providing immunisations, family education, illness prevention, developmental checks, all those things that we're doing for those bubbies, and ascertaining if any external supports may be beneficial for bub or for their whole family. And then lastly, we have the coordinated veterans care. Now, I understand this isn't relevant to every practice, but it would be remiss not to include the CVC program when we're talking about potentially preventable hospitalizations, because the CVC program has unplanned hospitalisation as the core of why the program actually exists. So many of the features of the program, like monthly nurse follow-up, are a great example of how regular communication with patients can make a really big impact on their long-term outcomes. So we've discussed the what, why and who of potentially preventable hospitalizations, and now we can get on to some practical stuff and examine how we can create a robust hospital avoidance strategy for the practice. If I can get it to load. There we go. All right, so we empower patients to identify risks So that might be things like what we were saying around empowering patients to identify if they have changes potentially relating to cancer that they need to bring to our attention. It might be that they are noticing a new symptom, an exacerbation of symptoms, whatever it may be, empowering the patient to recognise that and reach out to us because no one's in tune with the patient's body more than the patient themselves. We can plan proactive care. So we touched on this a little with those nurse follow-up visits, the benefit of proactively planning care and follow-up of things that we know that the patient is going to need throughout the year. And that might be diagnostic tests, administration of medications, vaccines, prescriptions, care plan reviews, visits to other providers in the care team. These are all predictable, and we can make life much easier for the patient and for the reception who are answering the phones by booking these visits in advance. Patient-focused SMART goals. So a goal that says reduce the HbA1c by 1% means absolutely nothing to the majority of patients. For chronic disease management to be effective, the patient requires goals that are specific, measurable, achievable, realistic and time-bound. So for example, that same patient living with diabetes might have a SMART goal to take my blood sugars twice a day before I eat and write the numbers in my book. It could be any 2 times a day because I'm a trachea and I don't have set break times. And we'll review this goal in 3 months to see how everything's going. If I have more than 3 sugar readings over a certain amount, I will call the nurse and seek some advice. That there is a very simple patient-focused SMART goal, and it's something that is going to mean a lot more to the patient than just numbers on the page. So utilising a team approach. So every member of your practice team has a part to play in hospital avoidance. Not every patient needs to see the GP for advice every time. Some patients will greatly benefit from using telehealth. And whilst the roles of a GP and the nurse are pretty clear, we also need to acknowledge the role of the admin teams who are facilitating appointments, phoning patients to make appointments for result recalls, the role that admin have in collecting and maintaining the correct information every visit, and identifying our Indigenous patients to ensure that we're providing the most culturally appropriate care, and booking the appropriate vaccine intervals as advised by the clinical team. So it really does take the whole team to be able to provide the best patient care. We want to maintain regular care as much as possible. So things like wound care, injections, immunisations, they're all just as important as the COVID vaccine rollout. And I know that's really tricky right now because that is, the vaccines are what your patients are asking for, and that's fabulous. Of course, we want everyone to be vaccinated, but we also need to balance that with making sure that we're not letting these patients slip through the gaps, because something as simple as providing regular wound care or routine immunisation is actually putting the patient at greater risk, and we really don't want to sort of create problems that don't need to be there. The communication. As I said previously, a whole of team approach is just so important to ensure everybody is on the same page and patients are receiving consistent messaging and accessing the right care where they need it. Please communicate regularly with your team and with your patients to ensure that everybody knows what's going on. Some practices will use daily huddles, some will use a communication book. Whatever works for your practice. We know a lot of practices have gone to using online Zoom and whatnot to do their staff meetings to avoid everybody being in the same place at the same time. It really doesn't matter how you do it. We want you to obviously make it individual for your practice, but so that everybody knows what's happening, especially while things are changing so often. So we want to talk to patients and practice staff about sick day plans. And this is a really important part of these potentially preventable hospitalizations. Because when we're talking about sick day plans, this isn't the day-to-day care that we have in the GP management plan or the team care arrangement. But this is what to do in exceptional events, which might contribute to a potentially preventable hospitalisation if we don't manage these issues early. Medication use. So medication errors count towards a significant number of potentially preventable hospitalizations every year. We can assist patients with the safe use of medications by ensuring that they understand their medicines, what they're for, how to take them, why they take them, are they taking them correctly. We can make a note of over-the-counter medicines that the patient might be taking so that we can detect any potential interactions. We can have conversations with patients around dose aids and also include the patient's regular pharmacist in the care team where they're able to provide a lot of education support, which may be something as formal as a home medicine review, right down to just simple, how are you managing with that? Do you understand medicine and how it works for you? And although this is the last point on this slide, probably the most important one when we're talking about hospital avoidance, which is ensuring timely access to care when it's needed. Now, I know everyone probably just rolled their eyes and went, yeah, we would if we could get doctors. I get it. It is a really tricky space. But it is what it is. And we know that when patients become unwell, we need to be able to get them in to see the right person in the right place at the right time. Because that's going to be the biggest factor in preventing deterioration of what's going on. So when we go back to that point of communication with the team, things that you might do to ensure patients have timely access to care might be making a note that they're on a chronic disease management pathway, or that the patient is always to be put through to the nurse. The expected intervals between visits, for example, a 10987 visit in 1 month unless advised otherwise. Reserving adequate appointments for the unexpected is of vital importance. So, of course, you're required to have a number of book-on-the-day appointments for your accreditation, but also considering things like triage appointments or a daily wait list where you're recording a brief reason that the patient's requesting a visit in the appointment notes, and that will allow the GP or the practice nurse to be able to triage those appointments and identify any high-risk patients that might need to be brought in rather than just being turned away because, no, sorry, our schedule's full for today. And then last one from me is monitoring how we manage our patients who are at risk. We're going back to PenCat. I wanted to mention the searches relating to monitoring patients most at risk. So we can measure screening interventions, medically complex patients, and completion of best practice interventions for management of certain chronic conditions. And then we can also use the cleansing cat tool to identify missing data to ensure that our searches are capturing the right patients by identifying those with high risk factors or a clear diagnosis, but they just haven't been entered correctly into the clinical software. So the other tool that's available to practice in our Hunter New England and Central Coast regions is Lumos. So while PenCat tells us what's happening within our practice, Lumos links to external health providers to give us an idea of what happens with our patients outside of the practice. And James is going to give us a bit more information about that. Thanks, James.
Lovely, thanks, Sarah. Good afternoon, everyone. And thanks for those helpful tips to support our patients in minimising their attendance at hospital. My name's James and I'm the PCIO project lead for Lumos. I would like to firstly provide just a quick overview of what the Lumos project is and demonstrate how the practice level reports provided can help to be a useful tool to inform decision making through the use of linked quality data. Lumos is a partnership initiative between the Hunter New England and Central Coast Primary Health Network and the New South Wales Ministry of Health. It also includes all of the other PHNs linking with the Ministry of Health. It is an ethically approved program that securely links data sets across many primary care emergency departments, hospital admissions, outpatients, ambulatory, and mortality. The data linked is from the same data that's already submitted by general practice through their de-identified uploads of data through QIPIP. And the quality of this data is due to the successful transition of general practice and coding of patient data. It is also being given a very high rating and was independently assessed by the former New South Wales Deputy Privacy Commissioner, who undertook an independent assessment in 2020 and stated that the Lumos program was well designed to protect patient privacy to a very high degree. Lumos provides practices with an opportunity to see previously unknown data trends, focusing on patient journeys through aggregated interaction points with participating practices and the broader health system. You can see the little blurb on the little snapshot on the side there that is talking about bringing all those data sets together. As the Lumos program evolves, it is envisioned that the information available will support the strategic identification and prioritisation of patient healthcare across all sectors. And same with that other little excerpt, it notes that the scale up and use of linked data sets can contribute to new knowledge in the public health, in health promotion, economics, and evidence-based clinical care. That's an excerpt from a peer-reviewed journal. Lumos practice reports are provided biannually to those practices who have consented and have their data linked with the ministry. They show patient encounters with your practice and then their interactions with those linked data sets, locations as noted previously. Each report includes a specific condition in focus as a separate page, which provides a more in-depth review of relevant parameters for the chosen topic. So these in the past have included diabetes and mental health. Next slide, please, Sarah. So I have pulled together some extracts from a sample Lumos report. So these aren't actual excerpts from practice reports. We have a sample one that helps to protect the confidentiality of those participating practices. However, the findings noted within these excerpts are utilizing the real data from those reports. The benefit to practices in having access to this collated high-level data sets is in the identification of unique trends that can be overlaid with individual practice dynamics. For example, if your practice has specialist GPs, if they are RMO, are they co-located with the hospital itself, your actual staff capacity, and where they're located, like a rural setting. So it also is overlaid with the circumstances of the report period. So this report actually covers approximately 4 months or the latest report does 4 months of the initial commencement of the of COVID and the global pandemic. So, and its impacts on Australia, which is the financial year 2019 to 2020. So there's approximately 4 months there. Additionally, Lumos offers an opportunity to review these findings against the average for all participating practices. So you'll see in the graphs that there are other, so the yellow indicates the practice itself, the green indicates the PHN, the local PHN averages, and then the blue lines indicate all of the PHN average. So comparisons don't necessarily reflect a positive or negative performance by a practice. And of course, when overlaid with, like I said, the dynamics of the practice itself, is really about identifying trends or anomalies that you can look further into utilising other reports like your PHN dashboard report, and then more in depth using your Cat4 software. So the first graph there is just a comparison of age and sex data assets in creating, which can create a clearer profile for your patient cohort. So if you have a large number of patients aged 40 to 50, you might want to consider some preventative opportunities for care, so care assessments and things. Also, maybe if you've got a large cohort of 0 to 14 age children, there could be some potential there for nurse-led clinics. And again, this is all taking into consideration the opportunity to reduce presentation at hospital. The second graph is an overview of the average socioeconomic status for the patients within these cohorts as well, within the practice, against the PHN and all PHNs. So it could identify if you have a large number of your patients who are in the most disadvantaged areas. This could lead to some concessions around bulk billing, or greater concessions around bulk billing, or targeted clinics for those socially determinant lifestyle risk factors, like Sarah alluded to with smoking cessation, and maybe some targeted diet type related clinics. And the third graph here is a bit of an overview of the chronic condition patient profile, which provides a snapshot of common diseases, again mapped against the PHN and all PHN's averages. So we all know the key role of the GPs in diagnosis, care planning, and management of the patients, which is well documented. This is especially relevant for minimising presentations at hospital. So the table below can assist with service decisions related to these areas. For example, maybe if you have a low incidence of patients with diagnosed hyperlipidemia, this may encourage you to do more screening in this area, as we know it can indicate and increase the risk of early coronary artery disease and heart attack. Next slide, please, Sarah. Thank you. So with this one, I thought I would pull out some extracts from further in the report. This is a very small snapshot of what is available. And this first graph I'm using the PHN data here as an overall average to look at some trends. So the comparison data between the last two previous Lumos reports, we identified a slight drop of approximately 1% across the PHN of cancer diagnosis. Now, the context here was there was an overall increase of 46 patients between those reports because of more practices coming on board with Lumos, and it also included the first 4 months of the COVID-19 pandemic. So if anything, you would probably expect it to rise slightly, as well as or at least hold steady, but probably shows the initial commencement of some of that the avoidance at attending general practice for those regular screenings. The second graph shows the amount of encounters for the practice with practices, and I've looked at the PHN data here as well, and it showed a 6% drop of patients attending practices between reports of 1 to 5 times within the PHN catchment area. So for me, this could identify the start of a level of avoidance with general practice growing in the early stages of the pandemic. A recent study actually that Lumos conducted, or the ministry conducted, with using Lumos data, identified 198 participating practices and sought to see if there was a correlation between existing general practice visits and ED or hospital admissions. It found that 22% of practices, they tended to be outside of major cities, and smaller practices were considered high frequency services. So that is defined as 30% of patients visited the practice at least 12 times in 2 years. The finding here was that the practices where the patients attended at a higher frequency were 10% less likely to have ED presentations and 12% less likely to have unplanned hospital admissions. So this could draw a link with the accessibility and attendance at general practice. Finally, the last graph reflects the incidence of main diagnosis and presentation to hospital. So obviously before they presented at hospital, and then the additional diagnoses provided during an interaction at hospital. This can demonstrate an opportunity to increase focus on a particular area also. So as indicated before in the reduction of cancer screenings during the pandemic, if you found that your practices were sitting a bit lower with the main diagnosis at hospital, and then there was a significant increase above the average of diagnoses at hospital, this could indicate an opportunity to increase your screening of cancer patients or patients for cancer. And that is just a brief overview of some of the data that is available through Lumos, and that could be interpreted to show trends within particular areas. And the last slide, please, Sarah. So I just want a quick plug. If you'd like to access more information about Lumos, you can click here on that little yellow tab there. Once you've downloaded this presentation, it has a lot more information, and you can actually access the sample report, so you can see what the report actually does cover. Additionally, if you'd like to access your free Lumos report, you only need to contact your local PCIO, or you can contact me via email, and we can commence that process. Also, if you're quick, you can still make the next Lumos linkage, which occurs early October, and you can help us get back to leading the state in recruitment for this first of its kind initiative. We've also started to develop an online community of practice, which is coming soon. So if you'd like more information about that too, we will have more information coming out to practices shortly. Thank you. That's all from me for Lumos.
Thanks, James, and thanks, Sarah. That was really informative. So now questions, I'll just encourage you to pop them in the box. We're running a little bit over time, so we've got a couple that have come in. Sarah, how do we follow up visits over the phone, and can they be done over the phone?
Okay, thanks, Mel. Yeah, so it's a bit tricky because the nurse follow-up visits are not on the GP telehealth information sheet. They're actually on the allied health telehealth information sheet on the MBS. But yes, both phone and video telehealth items have been extended to, I think it's December. So you do still have those options while your patients are not coming into the practice to be able to contact them at home.
Great, thank you. And the final question was, if a nurse is doing a follow-up visit, does the GP need to see the patient on the same day?
No. So, I mean, obviously, if you detected something that was an issue, absolutely, you would be referring them to the patient to see the doctor. But no, the descriptor for the MBS nurse items states that the patient can actually come in and just see the nurse to receive the follow-up care without needing to see the doctor on the same day.
Okay, fantastic. I'd like to thank you both for presenting today and being here. Really appreciate your time, and to thank everyone else for tuning in to the session. And a reminder, there will be a poll at the end of the session that's going to pop up, so I encourage you to complete that, and a copy of this and the presentation will be available in our education library. So thanks, Sarah, thanks, James, and thank you to everyone. Have a lovely afternoon.
Thank you.
Thanks, Mel. Thanks, everyone. Bye.
Mm-hmm.